So I want you to be aware of some other writers in this field. Dr. Peter Fonagy out of the UK has written quite a bit compassionately about what is called borderline personality. He has a theory called mentalization, which is very interesting, and it's about how we, in interaction in that attachment time, it's how we mentalize things, how we image things based on what's presented to us and the interaction and the attunement that goes on in attachment style. These are all articles that are available for free online, and I believe you have these in your resource list. I'm going to take us to this introduction to BPD Causes. So in this introduction to borderline personality disorder causes, even the DSM says that there's usually abuse or neglect. So that's there, and for all to see. It's very puzzling to me how that doctors and other people who write people off with this don't see that part. And also, it's also very puzzling to me that we can call it personality traits when in the DSM diagnosis there is information about abuse. So we call one form of that PTSD, and another form we call borderline personality. I don't get it. So as you can tell, I kind of don't really buy into the whole personality disorder theory. And we'll talk about that a little bit more in a minute. So about halfway down the page it says there's a strong evidence to support a link between distressing childhood experiences, particularly involving caregivers and BPD. Abuse, early separation, emotional physical neglect, emotional abuse, parental insensitivity. Marshall Linehan, who has come out a couple of years ago, finally admitting, if you've ever seen her videos, you go, oh, come on, really, you're not? That she has this condition, as it's called, but she talks about growing up in Oklahoma in a large family and being hospitalized for trying to set herself on fire at 17 years old, but she doesn't say she has any trauma, which is always curious to me. So, as I said, I've had a lot of DBT training. I feel it's very valuable stuff. So this emotionally invalidating environment that sometimes exists for people is very important for us to keep in mind. When people perceive that that's being created in their services, in their home life, then they'll have a response to it. And we need to keep in mind, again, this is trauma response. For some, we don't see that so much, again, but in my case, I've always, even when there's no outright abuse or neglect, usually I hear there's a critical voice in that person's life somewhere. There may be some genes involved, of course. The research is ongoing. So this is what I've kind of conceived as healthy versus ambivalent attachment primarily. In healthy relationship, the child receives enough attention, affection, and love, whatever that might mean in that person's case. The adult can accept rejection and move on. The adult can trust and be trustworthy. The adult can engage in give and take and can conceive of dialecticals, especially in relationship interactions. They're able to hear, I'm mad at you, and know their person still loves them. They don't automatically jump to, you hate me. However, in an ambivalent person, in childhood, they might receive inconsistent attention, sometimes rejection and abuse. That adult is seen as needy, attention-seeking, manipulative. The adult has difficulty trusting, is not consistently trustworthy. I tell people in therapy, trust goes both ways. If you don't show up a lot, I don't trust you anymore. And I might not schedule you again. You have to earn that privilege back by showing up a couple times. So it's very important to model these things for people and to show them that you can still be in a relationship with them, not cut them off if they've been untrustworthy. But very often people will come in carrying the story that I can't trust you, I can't trust anyone. So I talk to people about trust, not being an all or nothing kind of thing. And I learned this when I was working with so-called high-functioning, mentally challenged folks who had had a lot of trauma, and in my opinion were being re-traumatized where they were being served. And they would come in and say, I don't trust anybody, I don't trust anybody. And I would say, well, how did you get here today? A staff person brought me. I said, well, do you know that staff person? Yeah. I said, on a scale of 1 to 6 or 1 to 10, 1 being you were so scared that you wouldn't get here safely, that you wouldn't get in the car, and 10, you pretty much knew you were going to get here safely. How much did you really trust that person to get you here? About a 6 because they had an accident last week. Okay, that's reasonable. So you teach people that trust is not all or nothing, and we trust different people for different things. It's a very big issue for people with trauma, and we need to be able to talk about it as, again, not in black and white terms. So the adult perceives that all is personal, has difficulty hearing no, perceives rejection, either or thinking is in place there. They may put a new friend on a pedestal and then quickly become critical. So again, there are lots of degrees of this. It's trauma response most likely, and we need to get to know it that way so that we can let go of our judgment, because the judgment is something that people can really feel, and it gets in the way of any kind of services we're going to give them. We have to be straight with people. We don't go behind doors and talk about their behavior and snicker and criticize. Don't get me wrong, everybody needs to vent a little bit, even me. But for the most part, if you deal with people directly and explain to them, you know, I think this might be why you're doing this. What do you think? Then you're engaging them versus cutting them off with judgment, which doesn't get anybody anywhere. So Theodore Milan was a psychologist who had a lot to do with the formation of the diagnosis. And this is 4 categories that he had for borderline personality, or what were called borderlines. That is, discouraged borderline includes avoidant, depressive, or dependent behaviors. Impulsive borderline includes antisocial or approval-seeking behaviors. This one's really great. Petulant. Here's the definition of petulant, by the way. Childishly sulky or bad-tempered. Here's some synonyms. Peevish, bad-tempered, querulous, pettish, fretful, cross, irritable, sulky, snappish, crotchety, touchy, tetchy, testy, fractious, grumpy, disgruntled, crabby. That's really a scientific clinical term, isn't it? How'd you like to be indicated that's who you were? Petulant borderline includes passive-aggressive behaviors. Self-destructive borderline includes depressive or self-destructive behaviors. So I say let's try this again, but with a trauma-informed care perspective. Discouraged survivor, learned behavior, learned avoidance, learned depression, learned dependent behaviors. Impulsive survivor, learned antisocial or approval-seeking behaviors out of their experience. And I couldn't even come up with one for petulant, so I didn't even try. Childlike survivor, learned push-pull, ambivalent behaviors. Self-destructive survivor learned suicidal, self-blame as defense behaviors. What do you think about that distinction? How would it help you deal with people to be thinking this way versus that way? Words carry a lot of weight. And again, most of us are using some form of cognitive work. How can we possibly teach people not to label themselves and other people when we're doing it in negative ways? So if we really get a handle on this, we won't do it. And it won't get in the way of their treatment and our relationship with them. All of these behaviors are ways of being developed as a response and as a defense in our symptoms of complex PTSD. So here are some resources that you can use. And amazingly, most of these are available for book exams at traumainformedtraining.com. Isn't that great? Or they soon will be. Treating Complex Traumatic Stress Disorders is fairly new with Christine Courteau and John Ford. I just did an exam. It's almost finished for the one for children and adolescents, and it's just phenomenal. I'm amazed that it's going to be required for the second level certification. Traumatic Stress is an updated version of Bessel van der Kolk's book, Dialectical Behavior Therapy with Suicidal Adolescents by Alec Miller and some others out of Brooklyn. I did a training with Alec Miller. They do wonderful work with adolescents and their families. They require the families to come and learn the skills with the adolescents. And then Dr. Ross is the trauma model. It'll give you more background on these 2 concepts, the ambivalent attachment and internalized blame of self. So how does this manifest? Again, self-sabotage. People may have unfinished educations, frequent employment changes, broken relationships. They may start mental health services and then not show up after a couple of times. So how do we feel about that? Yes, it's frustrating, especially when you're in private practice. You don't get paid when people don't show up. It can be very, very frustrating. So you have to view this with compassion and balance. You have to help people get there. Unhealthy relationships, the person can become a perpetrator and or a victim. There's low self-esteem issues. This may be expressed passively or with hostility via addiction, self-harm, and suicide attempts, and that fragmentation that happens for people. It may be just in labeling, I'm just a loser. We have people come in and they're dressed nicely, their nails are done, you know, for women, or maybe not, and makeup, whatever, and they sit there and say how ugly they are. You can be annoyed by that, or you can help them. Sometimes I get a mirror out and I help them do a reality check with compassion. When you do it with compassion, people can usually hear it. When it's not an accusation, people can usually hear it. Self-harm I see as a love and hate of self, because people get something out of self-harm. They may get a relief of pain, or they may feel some pain when they don't usually feel pain, and they don't feel that they want to feel some pain. So they're giving themselves something, but then they hate themselves for doing it, as with any addiction. I've had people tell me the only time they get any attention from their family members is when they're in the hospital. I had a person tell me, a very accomplished person who kept a pretty she had a great education, and it was a really important job that she had, and she was hospitalized probably 5 or 6 times a year for a week at a time. And she finally told me, that's the only time that I go there because somebody takes care of me. So she had to learn that she needed to give that to herself. That getting it from other people would never, ever fill her up. And that's where you have to be straight with people and kind at the same time. Sometimes people will kind of evoke, kind of put out there, take care of me. But then when you try to, they'll pull back. Leave me alone. I don't want you to take care of me. This can especially happen with teens. So here's a case study. This client's 14 years old, grew up in a home with several IV drug users, absent of adult oversight. There are additional criminal behaviors present in the home, very little food in the home. Cult members lived in the home from time to time, as described by this client and parents. And this is kind of a composite of several. The client's adult caretaker was often absent and was supposedly diagnosed with narcolepsy and found sleeping on the driveway lots of times. The client often was found by neighbors several blocks away, and this was when the client was 2 and 3 years old, and returned to the home. From 12 years old, the client indicates that she's been very promiscuous. The mother is not supportive of treatment, is kind of mad and resentful that the teen's problem child behavior has become public now. The mother says she just went crazy one day. I don't know what happened to her. The biological father is absent and is described as having been mentally ill, and the step-parent's a meth user. So the behavior via the medical model, as this person's case played out, was more promiscuity, drugs and alcohol, runaway, cutting, suicide threats, vandalism, and truancy. Although when she attended school, she was an A student. I've seen so many of these, and I don't understand. Why don't people question this? Why don't you question, why is this person hurting themselves like this, and yet they're an A student when they go to school, or whatever else their talent is? Here's some of the diagnoses and treatment this person received. Oppositional defiant, attention deficit, conduct disorder. The person received treatment via Prozac, Seroquel, Abilify, Tegretol, Ritalin, and others too numerous to mention. Many psychiatric hospitalizations and residential treatment, of course, where restraints were used. Eventually, this person left home as a teen, living with abusive boyfriends, using drugs, alcohol, and so on, dropped out of school as an adult, multiple suicide attempts, drug use, recipient of Social Security benefits, halfway finished a master's degree, and was still on many, many medications before she got into some skills-based therapy. And now has a life. Doesn't use Social Security anymore. But how would you work with a person like this? Is this an alien case? Have you never heard of a case like this? Or have you had these cases? If you haven't, you will. If you choose to work with trauma, you definitely will. So you first of all have to, especially when we're talking about teens, but anyone, you have to validate the experience that the person expresses. Hear it, listen to it. You've got to explain that self-blame as a coping skill kind of thing. And the ambivalent attachment, because they have this stuff and they express it and they don't get it. It's just how they are. I say you have to find something like the puppy story to explain that this is your reality. You're not crazy. You didn't make yourself this way. Yes, the way you were treated created this. And how are you going to take responsibility for yourself? I can help you with that. So the two-sided nature of recovery. You start with skills work, a lot of cognitive work, and things like DBT. This is really important. You got to work with what is versus what you'd like the family to be. In family work and in addictions work, we're always told the family is the best support, the family is the best support. And I go, huh? Why do you think the person's drinking? They went through all this stuff in their family. It doesn't mean the family's the enemy, but you have to put everything in context, because it re-traumatizes people and invalidates their experience when, in treatment, they're in treatment for 30 days. They know that they're, maybe they're an adult, a young adult. They know their dad's still home drinking beer every night. And he didn't particularly get the DUI this time, so he's not in treatment. The kid is. And so we have to really look at that and how we view the family. The family is not sacred in the sense that they can do no wrong, and they're not also the devil. People need help, they need compassion, they need support. So I use what I call a lot of compassionate confrontation to hold the space of therapy, meaning I'm direct with people. I tell people I'm on your side. I want what you want for you, whatever your best life is for you, as long as it's not illegal or hurting children. And how can I help you do that? And I have to confront things when people show up 20 minutes late for therapy every week after week after week. I have to make that into a therapy concern and deal with it. If I don't, I'm going to build a resentment and it's going to get in the way of that person's therapy and it's going to escalate. I have to be authentic. I have to come across as an authentic, I have to be an authentic person. That's why I ask you to think about, why are you here? What are you doing this work for? Now we all, and those of you who are going to come to the mask workshop tomorrow, we'll talk about this a little bit tomorrow. We all wear masks. They're not bad things. We all put on an actor or an actress from time to time to fulfill our various roles. But do we let some of our authenticity come through? For some reason, I'm 61 next month, and I can still remember what it's like to be a 16-year-old. And I can relate to kids along those lines, but I don't have to be phony. I don't know everything about what's going on in their world right now. But I don't have a problem in a therapy session getting on and looking at something at YouTube, because it can be very, very useful to do those kinds of things. You need to be straight and clear, again, especially about these ambivalent attachment issues. People are used to having been criticized and just pushed along, ignored, and invalidated. We need to not get on the boat with them and criticizing all their past treatment, but we do need to acknowledge the reality of that with them. Role play is a really good way to help people get points with this stuff. And so if you're into psychodrama or anything like that, you're ahead of the game, I think. I just use plain old trip along role play. But it really does work to help people get into someone else's shoes and see another point of view. You've got to have firm, reasonable boundaries. One thing, I'm seeing some people frown, and I wonder if it's because of that next sentence. Adults can't be abandoned. What is your response when I say, I believe adults can't be abandoned? What's abandonment about? If you're abandoned, what do you have? Do you have anything if you're abandoned? You're left without resources. Children can be abandoned. They don't have resources. Adults have resources. They might not realize they have resources. And that's why I tell people, because people are, you're going to abandon me because you're going on vacation. And I was like, no. You have this support group, and you have your journal, and you have this and that, and you have an appointment when I come back. And so people can re-experience the feelings of abandonment. But it's very important for adults to know that, you know what, you have resources now. That doesn't mean you're all by yourself, and I really don't like the term pull yourself up by your bootstraps, because I don't believe anybody does. I didn't go to college at 40 years old all by myself. I had a lot of help in a lot of different ways. So that's a very important one. We need to learn to moderate extremes and normalize experience, because some of what people with, especially dissociation and this ambivalent stuff, some of what they're experiencing is kind of normal, what everybody else does. But because it's been in the context of their trauma experience, they take it all as if it's all just, they're the only ones, they're terminally unique. They're the only ones that experience this. And in a kind and gentle way, and compassionate way, you can share with them that, oh gosh, you know what, really a lot of people experience this, or I do sometimes experience this or that. I use what I call judicious self-disclosure. I'm a person with a past. And I claim being a wounded healer. And while it's their therapy, not mine, when I'm sitting with them, I do use what I call judicious use of self-disclosure to let them know I'm a human. You know, in substance abuse treatment, it's practically required that you have your own history of recovery from some addiction. In mental health, we have kind of this shame that we're not supposed to talk about our past. I think that's detrimental. And there's balance with everything. Anybody have any questions, comments? Okay. So the other thing that we need to keep in mind is, and there are many, many different ways to term this. You've probably learned about it in various places, but I call it, the way I learned it with Dr. Ross, is the victim rescuer perpetrator triangle. We need to keep in mind that this is what people grew up with when there's neglect and abuse and chaos going on and dysfunction. That people's roles weren't very clearly defined. And the thing is that victims, people who have been victims, can very easily claim being the victim or rescuer, but they have a really hard time claiming when they're a perpetrator of something. So here's a good example. Sometimes in relationships, one person will be the one that's kind of out loud, a screamer or a yeller, and the other person will kind of shut down and do the silent treatment, right? Both of those people are really in defense mode when they're doing those things. And usually the person that does the silent treatment never sees that as victimizing anyone. But really, I've had people tell me that was just as violent to me as being hit when my spouse wouldn't talk to me for a week and even explain to me why they're mad at me. So we need to look at this and help people see this is human experience. We all do this in some way or another. And so the victim perpetrator rescuer triangle is something that we help people learn how to step out of. I believe very strongly, in my second level of certification, we'll get into this, I believe strongly that what we call codependence is all about internalized blame of self, ambivalent attachment, and victim rescuer perpetrator triangulation. All those three things working together all the time in relationships. I think that makes up what we call codependence. So, next we are going to talk about how we can treat these conditions. Is everybody in this room in a position of treatment? If you're not, raise your hand. If you're not providing treatment. Can I ask what your role is?
I oversee.
Okay, so you're like a supervisor of people who are doing treatment. Okay, great. Anybody else raise their hand for that one? Yes?
Administration.
Okay. And so what is your role when it comes to treatment? Do you have anything to do with, allocating dollars for treatment? Okay. Okay.
That was just one quick point I wanted to bring up.
Mm-hmm.
Iowa's mental health disability system is undergoing a significant redesign, and one of the requirements as counties regionalize is that there is trauma-informed services. And it's something I've heard, but watching it put in a more practical sense is something our region is going to be working with providers on.
Great. That's wonderful to hear. Yes. So there's an administrator for you to talk to. That's wonderful to hear. And change is difficult, and things get lost and things get gained, and in the transition sometimes it's hard to see what's what. So hang in there, and I'm so happy you're here. Okay. So we're going to go now to, I don't think I brought it up. to the next one. So, treatment principles and an overview of treatment models. There's no way in probably an hour and a half or less I can cover everything about treatment. So that's why there's going to be a level 2 and a level 3 and a level 4 to my certification program. There's a lot to this. So what's the role of evidence-based? We're going to look at that. How's the paradigm shift going to affect treatment? What is the criteria for a useful model, in my opinion? We're going to look at an overview of models, application of these concepts in treatment, and then what are some treatment issues that come up. Not everything that can be counted counts. Not everything that counts can be counted. Something important to keep in mind when we're talking about evidence-based, because as with everything, it's two-sided and we need balance. So I want you to keep in mind your critical thinking skills. I don't mean be a critic. I mean keep in mind your critical thinking skills. And this one is important too. This is a good thing, because sometimes what I see happening, especially in agencies, is people are getting sent to treatment training. They get 3 hours of training, and then they come back and they've got the responsibility of doing DBT groups with 20 people with ambivalent attachment issues, which is what I call the BPD, okay, or complex trauma. And they don't have the confidence to set good boundaries. They don't have the confidence to deal with the things that come up. They don't have the understanding of what goes behind using those skills. And I see a lot of harm come out of that. And so that's something I want you to keep in mind. If you're being sent to training for something for your agency, don't just do the training. Do some deeper study and see how these things are going to be implemented, because, as we just heard, it's being mandated, trauma-informed training, and it can mean one thing or another in different places. So evidence-based is based on 3 basic components, actually. Best available research, clinical expertise, and in the context of patient preferences or patient choice, or your customer's choice, your client's choice. So this is the American Psychological Association's definition based on Sackett's work with deciding what is evidence-based. Evidence-based is something that's come up in the last 20 years or so. When I was working for the military, every day we got an email, are you using evidence-based modalities? Are you using evidence-based? I was like, yeah, well, I guess so, because I took the training and it's really what I've been doing all along. So good therapy is good therapy. Again, we got to think about that paradigm shift. Are we really coming from a place of what happened to you, or are we still back there and what's wrong with you? What's going to change in treatment? Assessment and diagnosis again, comorbidity, medication, and professional relationships. Assessment and diagnosis. Think about being a person who's grown up with chaos, maybe abuse, neglect, whatever. You're just trying to live your life. Maybe you're in your 20s, maybe you're even in your 30s and you have some kids now, or you're trying to go to school and you keep having to drop out because bad stuff keeps happening, and maybe you got into an addiction, or you're depressed, or you have a suicide attempt, maybe you have a lot of high anxiety, and you go in and you're going to ask for help now. What happens in a lot of places, most places? The first time a doctor, depending upon your insurance coverage, a doctor may spend 20 to 30 minutes with you. If you have less insurance coverage, they may spend 5 to 10 minutes with you. And they're going to give you a diagnosis. And what is that diagnosis going to mean in your life? Because you're floundering around figuring out what's going on with me. I don't feel good. I don't feel right. I'm not doing the things I want to do. What's going on? And so we got to remember, again, this denial is a coping defense. It's not like people are knocking down or banging down our doors, oh, please help me with my trauma. People are traumatized, but they're getting by the best they can. So we need to learn ways to explain it to them so that it's not something that is denigrating to them. We need to normalize it and let them know we're all traumatized in some way or another. Everybody goes through some kind of trauma. And then don't minimize theirs as well. The ACE questions, I think, are essential for any intake process anywhere. Those questions need to be asked, and people say, well, how can I ask those questions? In Arizona, they passed some law that we had to start asking people about their sexual identity, whether they identified as transgender, as gay, as straight, all these things. And I got training for the trainer, and I did some of the training, and everybody's objection was, I can't ask them that, I can't ask people that. And, you know, granted, there were some situations that even after that training, I didn't ask people. But it's how we ask these things. How do we put this out there to people? Are we matter of fact about it? Are we condescending about it? Are we punitive, or are we authoritarian about it? Are we person to person? That's where being authentic comes in. So when we ask these ACE questions, we let people know, we ask everyone these questions. It gives us information that will help us help you. That's how you put it to them. Getting a diagnosis can be a pivotal moment for a person. Perhaps they've been floundering around for years, and now they've been reading stuff about bipolar, and they go and they talk to the doctor, and he sees them for 5 minutes. He goes, yeah, you're bipolar. Well, they're going to be elated for a while. Oh, they got their answers now. Other people, not so much. Now I'm crazy just like my mom. I don't want to be like my mom. My mom was crazy. So it's a pivotal moment for a person. And sometimes we don't even tell them what their diagnoses are. In doctor's offices, that's very common. I mean, a lot of people at the crisis center, I'd have their whole file, and I go, gosh, was it this diagnosis and this diagnosis and this? What was going on in your life? And I go, I didn't know I had that diagnosis. I didn't know I had that. I didn't know I had that. And there I am now telling them all of it at once. So it can either affirm, condemn, or become something useless. And it can become something that guides treatment, or it can be something that the person learns to live the labels in order just to get by and get their needs met the best they can. Or to live their family's story for them, or whatever it happens to be. Don't forget this picture. Okay? Denial is the first coping defense for victimization. And so we have to learn ways to help people through that. I even tell people that, you know, that's how you got by. But something's not working for you now that you're here at the crisis center, or here in my office, or here in the hospital, or here in the addictions treatment. So here's another case example that I call multiple diagnosis disorder. This person's file, and this is very typical, in my experience anyway, working in various places. This person has been diagnosed with bipolar 2, major depression, anxiety, obsessive compulsive disorder, borderline personality disorder, avoidant personality disorder, post-traumatic stress disorder, ADHD in childhood, oppositional and conduct disorder in childhood. So this is the person you're going to go and interview now. The client reports to you that they've been having suicidal thought with increasing intent and a plan. They have episodes of self-harm with cutting and bulimic behavior. They have excessive alcohol use and frequent use of marijuana. They describe chaotic relationships. They have many somatic complaints. They don't sleep well. They have nightmares. They hear a voice that commands them to self-hurt. They describe isolative behavior with periods of depression and anxiety. Further on, they reveal that several siblings were removed from their parents' custody due to the parents' narcotics use. The client was physically beaten in the foster care setting. The father was schizophrenic. The mother was bipolar. The client had their first sexual experience at 14 years old with a 20-year-old boy or girlfriend. I've sat with other people doing intakes where they go through that whole thing and they don't ever question, especially if it's a male, had intercourse with a 20-year-old woman when he was 14. They don't ever question it. I go, let's ask him about that experience. Was it what he wanted? Client has had several jobs in the last year, dropped out of college, and describes on and off relationships with family members and says no when you say, have you ever been abused? So, what factors do you consider? What do you think about the family members' diagnoses? Do you just accept those at face value? Do you ever question those? What do you question? I've had doctors say, oh, you can't believe everything people say when it's about trauma. It's like, okay, well, What about the validity of memories? That's a really deep subject, controversial one. How do you deal with that? What do you not question in this situation? Do you accept all those diagnoses as at face value? How would you diagnose the person? And what diagnoses might you expect from the doctor or prescriber in your setting? Would you differ from that doctor or prescriber in your setting? If you do differ, what would you do with that? All questions that many of you either do face, knowingly or unknowingly, or will face, now knowingly, hopefully. So again, here's our little cycle. And many people that come into our places of work, this is the cycle they've been through and their family has been through year after year after year. You have to take into account that this is what people are carrying with them. And what are you going to do that's different this time? Now, we talked about that self-blame as a defense, coping defense. When somebody in a white coat says, well, you have this diagnosis, well, that means I'm defective, I'm bad, so there you go. It's not about blame and shame, once again, but it is about facing realities. So this is Dr. Michael First, who's had lots to do with DSM work in the past, and he talks about subthreshold events. And what he says is the definition of post-traumatic stress disorder should change with the next revision, which is now passed, because this was back in 2002. He says, does presence of a PTSD syndrome automatically imply exposure to severe trauma? That is true only if PTSD can arise as a specific response to a severe trauma. However, if there are cases where PTSD develops in absence of severe trauma, it is not a valid assumption. It does not have to be a severe A1 level trauma to qualify for PTSD. And according to the book I just mentioned, Treatment of Complex Traumatic Stress in Children and Adolescents, the norm is not the person who walks into our offices and says, I was mugged last week and I grew up in a wonderful family. The norm is these people with poly-victimization, multiple traumas, year after year after year, sometimes from birth. And so when we talk about subthreshold events, we're talking about things like unresolved for the family, divorce and bereavement, end of a romantic or significant relationship, frequent and coming and going of significant adults in a child's life, sudden death of a loved one or significant person, especially with no real conversation or explanation about what was going on. Exposure to violence, domestic violence, community violence, school violence, frequent moves, a family member's traumatic event, poverty, job loss, and there are many, many others. So the idea then is that people, if they have PTSD symptoms, but they can't tell you one event, what do you do with that? So right now we don't have really a diagnosis that covers that. Dr. Vanderkook is trying to cover it, but it's not getting in there yet for some reason. Yes?
The DSM-5 has, obviously it's a work in progress.
Right.
But they've opened up that.
It is opened up, yes. It definitely has opened up a little bit. You're absolutely right, and that's because of this, especially with Dr. First, because he's had something to do with the past DSMs. Thank you for bringing that out. So what changes if we understand the nature of subthreshold events? Maybe we'll have a new framework for understanding so-called oppositional behavior of a child. Again, we use that term acting out, but we never stop and go, what are they acting out of? They're acting out of something. They're just the designated client. The presence of many of these conditions, subthreshold events, in a child's family life might indicate that there's what I like to call non-nurturing, not child-centered parenting, and can result in early life stressors that may cause adult depression, anxiety, and even post-traumatic stress disorder. That's a big statement. But there's a Dr. Charles Nemiroff who does a lot of really good research with rats. They traumatize infant rats, however they do that, and then in adulthood, they measure depression and anxiety in rats. And guess what they find? They find such a significant relationship that they can now cause it causal, not correlational, a causal effect of early life stressors to cause depression and anxiety in adulthood. And so again, a family may need help. I tell people that good enough parenting is what I call balanced, appropriately child-centered, nurturing parenting. Not too indulgent and not over here, punitive, balance. That looks different in different families. However, there's that continuum. Excuse me. So if there are many of these conditions in a child's life, you've got to take those things into account. And too often our programs focus on the kids, don't validate for them really what's going on at home, and get the whole family into treatment, and then the kids go on to create the next generations. This book, The Link Between Childhood Trauma and Mental Illness, is an exam on my website, and it's a fabulous book. I kept reading it and going, oh, this is the book I was going to write. I don't have to write it now. It really gets into this issue about the link between these early life experiences and then what we call mental illness later in life. This alternative way of viewing children's behavior can lead to a different treatment approach that includes family systems work versus targeting the kid as the problem and primarily utilizing medication to manage the problem, which is too often happening. Eliana Gill is a well-known figure in family treatment. This is another exam on my website. It was a very difficult book to use. To read for me. She uses a lot of case examples. She works with the whole family, including perpetrators, and has wonderful